Good afternoon, everyone. We are going to go ahead and get started. This is Summer Gathercole, serving as Senior Advisor for the Behavioral Health Task Force. Thank you for joining this webinar today. It is Thursday, December 5th, and we're excited that you are all here. This webinar is being recorded so that we can share it later. As you can see here on the screen, everyone who has entered was automatically muted upon entering the webinar. So we will get to some questions and answers and conversations later on. Please feel free to hit *6 to unmute yourself. And if you have already unmuted yourself, if you can mute yourself by hitting *6 again, just so that we can eliminate the background noise, that would be great. If you're using your computer, there are controls on your screen to determine how to mute and unmute yourself. And we are asking folks to just keep the video feature turned off just so that it's not too distracting as we're going through the webinar. You can definitely feel free to enter information in the chat box. If you can share your name and affiliation, that would be great. And if you have questions, I will do my best to monitor the chat box as we're going through today. So the purpose of this webinar is really to review the WICHE behavioral health funding study that was conducted back in 2016. We have talked a lot about this study as something that we've referenced, and so we wanted to spend a little bit more time just talking through the study, what was shared in terms of those recommendations, and what we should be considering now as we're looking at the behavioral health system going into 2020 in Colorado, and how we want to make some reforms and recommendations. So I'm going to start with what is WICHE, since we always refer to it as the acronym. WICHE stands for the Western Interstate Commission for Higher Education. It's a nonprofit organization. It's actually an interstate agency that's located here in Colorado in Boulder. It serves 16 states and territories, which you can see there on the screen. And it was really created to kind of facilitate resource sharing among the higher education systems of the West. It's governed by 3 gubernatorially appointed commissioners from each of its 16 members. So it has almost 50 people on its board of directors. And I think just knowing that they're gubernatorially appointed is important to know, just for reference going forward. So I wanted to talk a little bit about why this study was conducted in 2016. It was done in the context of looking at the impact of Medicaid Expansion and the Affordable Care Act. WICHE was really tasked at looking at our state systems that provide public behavioral health services, as well as funding allocation and reimbursement methodologies that are utilized by healthcare policy and finance, the Office of Behavioral Health, and then just in general, behavioral health service providers. WICHE, in doing this study, looked pretty closely at the indigent population in an attempt to identify kind of what are their unique needs. So that could help to inform the allocation of state funds for the indigent population. So the WICHE team was really tasked with examining a couple of things. One, an inventory of behavioral health funding sources in Colorado, including changes from the Affordable Care Act, mental health parity laws and regulations, and other state-level investments into the behavioral health system. They also looked at, or charged with making an inventory of changes to populations covered by public and private health insurance for behavioral health services, including the behavioral health funding needs of individuals who are insured, uninsured, and underinsured. They looked a little bit at the cost of operating a community mental health center, and then they provided some recommendations regarding the alignment of behavioral health funding across state agencies, including oversight and management of behavioral health services, allocation of Office of Behavioral Health funds, reimbursement for behavioral health services, and services provided to indigent clients with Office of Behavioral Health funds. So the one thing I just want to stress is that this study was completed in 2016. Obviously, there's been some changes things, and some things look pretty different right now. But this webinar is to talk through kind of what we learned from this study in 2016. So I'm going to continue to remind people throughout the webinar that this is based on 2016, and we know that there's been some changes since then. But on the other hand, what's really interesting is that we will hear a lot of similarities around the things that we have already talked about, both within the Safety Net Subcommittee and the task force. So that being said, what you see here on the screen is back in 2016, looking at the Office of Behavioral Health within the Colorado Department of Human Services. So if we just kind of step back for a minute and look at the state's behavioral health service delivery system, which includes mental health and substance use, it's comprised of multiple agencies, funding sources, and focuses of care. So we've got the two primary behavioral health agencies, the Office of Behavioral Health and the Department of Healthcare Policy and Financing. There's also an array of additional agencies that deliver or fund behavioral health services, so such as education, child welfare, juvenile and adult corrections. And there's other agencies that offer critical supports to people with behavioral health needs, such as housing, employment, and recovery supports. So the Office of Behavioral Health largely focuses on programs and services for individuals who are designated as indigent. And that's really those who earn less than 300% of the federal poverty level and have no other sources of funding, such as Medicaid, to pay for behavioral health services. That is where the Office of Behavioral Health spends most of its time, effort, and money, is around the indigent population, although there are a few funds set aside for clients who are not indigent. If you're looking at the screen here and you can see what the Office of Behavioral Health looked like in 2016, again, we know that this has changed. Since then, crisis agencies have changed, and so this is just a reflection of kind of what the structure looked like in 2016, and it's important to keep this lens in place as we're talking about the recommendations that came out of the WICHE study. So similarly, this is what the Department of Healthcare Policy and Financing looked like in 2016. This is before the RAES were established, and just as the RAES were starting to get established, as you can see there on the bottom left-hand corner of your screen. And then this is also before the BHOs went away. So you'll see, again, this is just to remind you a little bit about what Department of Healthcare and Financing, HCPF, looked like in 2016. What we know now is that HCPF has the RAES system and had established that for a number of reasons. The primary one, just to improve mental health, member health, and to reduce costs. So the purpose of kind of making that switch was to ensure that there's a focal point of care, that there's coordination across systems, which we're going to talk about some today, and then that there's this opportunity to make real-time decisions that improve care, increase the coordination of services, and improve overall efficiencies. So what you're going to see here on the screen is currently the 7 RAE regions that now exist. And as most of you know, this is in alignment with the Office of Behavioral Health crisis regions that have recently been established. So one of the things that we talked about at our last Safety Net Subcommittee is that there are, and you heard me reference this a few minutes ago, there are multiple agencies who are administering behavioral health services. Outside of what you see here on this list on the screen, there's also the Department of Education, there's the Division of Voc Rehab out of the Colorado Department of Labor and Employment. So when we think about it, this really kind of represents an impressive investment by the state of Colorado and local governments in the behavioral health of Coloradans. And the development of these services and supports were achieved through multiple efforts across many years to better organize, fund, expand access to, and improve the quality and responsiveness of behavioral health services. So all of how we got to where we are today, I think we can probably safely say it was with the best of intentions. Nevertheless, and despite kind of recent and a lot of attempts at increasing coordination, a lot of these agencies that you see here on the screen still operate in silos. Many of the agencies have their own structure, goals and purpose, eligibility requirements, service definitions, payment rates, payment mechanisms, financial reporting systems, client eligibility and service utilization data tracking systems and standards, program requirements, provider or practitioner registration or credentialing process, contract requirements, and criteria for quality or success. That is a long list of differing things across differing agencies that just make it even more harder and complicated and confusing for the consumer to access services. And at the same time, what we heard or what we saw in the WICHE report is that that type of situation or this type of situation creates inefficiencies. It's ineffective use of public resources. There's inability to account for overall system impacts on services, funding, and provider capacity. It puts a strain on providers and practitioners who are trying to navigate the various systems and requirements. As I said earlier, it's difficult for clients and families trying to obtain access to services, or if they want to complain about services, they don't know even where to submit those complaints. It leads to inefficiencies in the quality monitoring and oversight of provider performance and service delivery. And really, almost, most importantly, there's this inability to plan for or meet Colorado's healthcare needs, behavioral healthcare needs in a coherent, organized, and coordinated fashion. Because while Office of Behavioral Health is a federally identified agency in Colorado with respect to block grant funding and serving the indigent population, the Healthcare Policy and Finance is a federally identified Medicaid agency, and there's no identifiable behavioral health system leader with responsibility or authority across all the behavioral health care services in the state. Again, this is nothing new. We talked about this quite a bit at our last Safety Net Subcommittee and our task force as well. This is just a reminder, and you're going to hear me say this a lot throughout this webinar. It's just a reminder of how confusing and challenging it is currently. So if you did read through or peruse the WICHE funding study, it shared a lot of data and information. I am not going to go through all of that data and information on today's webinar, mostly because that was from 2016. Again, there's a lot that's changed. A lot of the numbers that were in that WICHE study were a result of Medicaid expansion and the Affordable Care Act. So we're not going to spend time today going through all that. A couple of things I did just want to point out, though, is that coming out of the WICHE study, what they really noticed is that while Colorado's population increased by 5% from 2012 to 2015, the total number of persons served in the public behavioral health system increased by 50%. So there's a huge, significant difference there. State spending for behavioral health services across all of our programs totaled nearly $1 billion in fiscal year 2014-15, having increased 63% from 3 years earlier. Right now, our statewide behavioral health funding is about $1.3 billion per year. During the time of this report in 2016, the Office of Behavioral Health spending for community programs increased by 36%, which is largely the result of new funding for crisis services and community transition services. And then while Medicaid and the fee-for-service program, their spending increased by over 100%, again, with the expansion at that time, not surprising. Talked a lot about already how the Office of Behavioral Health focuses on the indigent population. What they saw there is a decrease in serving that population by 43%, again, the result of Medicaid expansion. And just to reiterate, if you have read through or perused the WICHE report, there is a lot of data, a lot of numbers in their report in regards to the uninsured and underinsured populations, as well as the need at that time in 2016. Because that data is actually reflective of fiscal year 2014 and 15, we're not going to spend a lot of time on the numbers today in that data because there's so much that's changed over the last 4 to 5 years. So we're going to go through the recommendations in more detail, but just going to kind of jump ahead first to talk about the 3 key conclusions that resulted from the WICHE study. The first one being that while Colorado has increased behavioral health services and funding for those safety net populations, there are challenges that still remain. So the good news, as a result of Medicaid expansion, in 2016, more individuals were receiving behavioral health services than ever before. The number of uninsured Coloradans reduced. However, the number of underinsured Coloradans increased by 30% at the same time. Probably reflective of individuals who were insured, but challenged by the cost of insurance and healthcare, including those out-of-pocket expenses to reach their annual deductible amounts, and for co-payments related to services. A significant number of the safety net individuals with a serious behavioral health disorder had not received services, particularly those people who had a substance use disorder, so there's still a gap that needed to be addressed. And the difference in the average number of mental health services received by indigent clients within the Office of Behavioral Health in comparison to the Medicaid clients indicates that there were some disparities that exist in meeting the needs of those 2 populations. The second kind of key conclusion that came out of the WICHE report is that despite the fact that there were stronger state agency partnerships that developed during this time, the system is still fragmented and complex. And I would share that that is probably the same thing that we could say today. Going back to what I shared a few minutes ago, given the numerous state agencies that are providing services at many points along the behavioral health continuum, all the way from prevention to inpatient treatment, there's really no simple solution to improving the efficiency and effectiveness of the state's behavioral health organizational structure. And we're going to talk about that in more detail. Trying to kind of unilaterally move the authority and control of all behavioral health funding, planning, programs, and regulations into a single department and agency doesn't necessarily guarantee that the situation is going to improve and and it actually could create increased inefficiencies. And yet, on the other hand, centralizing the authority and the funding for behavioral health prevention programs, which are currently dispersed over several agencies, could lead to increased efficiencies and perhaps effectiveness. So that's a long way of saying there's nothing that's kind of very clear-cut and easy decisions to make. And while HCPF and OBH staff really work closely and in partnership, the continued kind of segregation of the management and administration of Medicaid and non-Medicaid behavioral health programs by HCPF and OBH just continue to cause confusion, both by the consumers and by the providers. So the third kind of conclusion coming out of that report is the funding allocation and reimbursement methodologies are complicated and error-prone. Again, I feel like this is something that we could still say today. You know, OBH has really built in, back in 2016, they had started to build in accountability and transparency into its reimbursement methodologies, and they've continued to do that since then. But I would say the requirement that providers use kind of multiple methods for obtaining reimbursement for contracted services just creates an administrative burden and requires more resources to be directed to those administrative and billing activities rather than be allocated towards providing services to clients. And again, this is something, especially as I've been going out and about across the state, I've heard time and time again that those administrative and billing activities are incredibly burdensome for the providers and stops them from being able to provide direct services to the people who need it the most. So despite also back in 2016, the efforts of Office of Behavioral Health and Healthcare Policy and Finance, significant challenges remained back then for clients and providers, because in the absence of the alignment of state agencies, contractors, and regions, the state at that time was relying pretty heavily on the provider doing self-monitoring, and there were limited audits to ensure that contractors were abiding by their terms and not using sources of funding to support, multiple sources of funding to support the same service. Again, we're going to talk a little bit more about kind of some of the recommendations that came out of that report, and discuss some what we need to be thinking about going forward. So here on this screen, you'll see kind of the 8 recommendations that resulted from the WICHE funding study. I'm not going to read these through to you just because we are going to discuss them one by one, but just wanted you to be aware that these are the 8 that we're going to be spending our time talking about for probably the next 20 minutes or so. So the first recommendation, oh, actually, let me back up first before we get into recommendations. This slide here kind of goes to what I was just saying a few minutes ago, is that, you know, it's not necessarily simple and straightforward solutions that we're talking about. We have heard, I think, over the past couple of years, and even talking within the Safety Net and the task force, that it would make a lot of sense to have more alignment of the state agencies, to maybe combine or consolidate the state agencies, because there's so many of them who are providing services at many points. While this is something that I think a lot of people are proponents of, one of the challenges highlighted by the WICHE study is that kind of moving all of the authority and the control of funding and planning and programs and regulation, still, it might result in increased inefficiencies. It doesn't necessarily agree that just because we align all of that, it's going to make everything more efficient. So the example that they gave in the WICHE report is that authority over behavioral health services delivered to adult and juvenile corrections populations while incarcerated should most likely remain with the agencies legally responsible for their care. That seems to make common sense. And yet, at the same time, having a centralized authority and kind of funding to support prevention programs that are currently dispersed across several agencies could lead to more increased efficiencies and perhaps even more effectiveness. So that's, again, a long way of saying nothing is black and white per se. All right, so we're going to move to our first recommendation here. Recommendation number 1, you know, really was to conduct a detailed review of those programs, the behavioral health programs outside of the purview of healthcare policy and finance and the Office of Behavioral Health. You know, back in 2016, what they said is that, you know, there have been efforts to improve the coordination of funding and reimbursement methods across departments and agencies. That had been discussed a lot back then. It's been discussed a lot since then. It's been examined over the years. And in conclusion, you know, not a lot of progress has been made. Interestingly enough, back then, the Office of Behavioral Health, Healthcare Policy and Finance, and the Department of Public Health and Environment actually released a report examining several barriers to integrated care, including kind of those administrative barriers, global barriers, federal barriers, and looked at all those challenges and kind of talked about the need to coordinate state agency goals to promote greater collective action among the providers to meet our behavioral health and general health care goals. That report was issued by and entitled the Tri-Agency Regulatory Alignment Initiative to Support Integrated Care. Again, recommendations that we've heard before, but necessarily haven't come to fruition yet. So I think looking at those programs outside of HCPF and OBH and how we might be able to better align some of those efforts will be important for the task force and the Safety Net Subcommittee. One of the things that the WICHE study also really highlighted is that despite Medicaid expansion, not everyone has had, or even now today has the insurance that they can use. So the significant increase in the number of underinsured, especially those with those individuals who are underinsured with a severe mental illness, really suggested that individuals who would have previously met the indigent income guidelines per OBH may now have health insurance and lack the money to meet the annual deductible and perhaps even the copayment amounts. So then they're not accessing the behavioral health care needs that they have. They're not accessing services, and they're not even trying to because they don't want to pay for the out-of-pocket fees. And this is, again, reflective of what we heard in 2016, and I think reflective of what we're still hearing today. I spoke at a conference yesterday, and someone came up to me afterwards and asked this exact same question of, is the task force talking about the underinsured population and the folks that really severely need services but aren't able to pay for them because of the co-payments or the deductibles? So it's, again, something that we will have to continue to talk about, especially within our Safety Net Subcommittee. So the second recommendation to come out of the WICHE study was investigating methods to assist people due to some of the health insurance policy changes. So this goes to exactly what we were just talking about, that there was, back in 2016, an increase in the number of underinsured individuals who were still not able to access services. And this continues based on what we're hearing from people with lived experience and their family members and caregivers. This continues to be a challenge. You know, back in 2016, per the WICHE study, there were several community mental health centers who reported a large increase in the number of clients who did not meet the indigent funding criteria because they had insurance but didn't have the funds to pay for services due to that kind of high deductible amounts for insurance coverage. So per the WICHE study, community mental health centers reported that these individuals were being turned away or prioritized for services after Medicaid clients and clients with other insurance. So this continues to be, a challenge to some degree, especially since I just heard about it yesterday, and something, again, that the Safety Net Subcommittee will need to continue to look at. So if you look at recommendation number 3, explore alternative payment approaches for the use of indigent funds. So back in 2016, OBH was using a case rate payment and target number of clients to provide the majority of funding for indigent clients. Setting the indigent case rate payment amount based on actual services utilized by the indigent clients seems, like a reasonable, kind of straightforward starting point. And yet, I think what we were finding then, or continuing to find now, is that the indigent population have service needs that differ from the services that they actually are receiving. So a greater proportion of those clients have higher elevated symptom severity levels. They are more likely to have kind of poor social support systems and socialization skills, and have a greater need for supervision and some of the kind of supports that we've talked around in terms of kind of housing, employment, and so forth. Typically, the indigent clientele also has a history of more severe mental health, substance use, legal issues. Again, all of those things that would probably fall into the work of the Safety Net Subcommittee. And I thought what was interesting is that similar to what we've been discussing most recently, the WICHE funding study suggested that the Office of Behavioral Health continue to explore ways to expand support for prevention and early intervention, as well as supportive housing, supportive employment, peer navigation services, in coordination with the Medicaid benefit. So that has those conversations have certainly been happening, have happened, and we've been able to make some progress, but probably still have a ways to go. I heard Robert Werthwein also spoke at the conference I was at yesterday. He talked about our safety net as it stands right now has lots of big holes, and those holes need to be addressed, and we need to fix those. So if we look at recommendation number 4, which is really kind of reducing or eliminating the payment of indigent client funding for Medicaid eligible people. So really looking at how do we maximize the resources that are available to us, and how do we look at what's currently happening and what do we do about it. So for instance, there are, back in 2016, even today, frequent changes in eligibility for Medicaid benefits place, a pretty significant administrative and financial burden on HCPF, other insurers, what was then the BHOs, now the RAES, and this churn, as we talked about it, which is really the exit and reentry of individuals from Medicaid eligibility, often due to fluctuations in income, a loss of a job, might be seasonal employment, overtime or bonus pay, changes in family circumstances. That churn, it's actually estimated that within a year, about 55% of Medicaid eligible people experience churn, so going off and getting back on Medicaid. The WICHE study actually conducted a review of a sample of indigent and Medicaid encounters to determine if the kind of all those different funding sources, if it's indigent, Medicaid, and third-party payers were being appropriately utilized. Those encounters were reviewed to determine if some of those encounters were used to reimburse community mental health centers for a Medicaid eligible individual who was enrolled at the time of service, looking at duplicate or identical encounters that were submitted, if the correct payer was utilized. And let me take a step back and just say that encounters are defined as an interaction between a patient and a healthcare provider for the purposes of providing services or assessing the health status of a patient. Encounter data are the records of those services delivered to Medicaid beneficiaries enrolled in managed care plans. So that's what we're talking about when we're talking about kind of the encounters and the encounter data. Back in 2016, when WICHE looked at the encounters within the Office of Behavioral Health, it did appear that the current system for reimbursement did sometimes result in payment errors. Sometimes it resulted in duplication of submissions and payer priorities. And so there's a lot of work that was suggested be done to improve that system. And what I would share with you today is that we still have a lot of work to do in that system. I've heard Robert say several times that when we look at our Medicaid system here in Colorado and HCPF, HCPF has a very kind of robust system for Medicaid. Office of Behavioral Health is still relying on Excel, which leaves room for lots of error. So there's definitely room for improvement there. And I think this recommendation certainly still is something that's important to keep in mind. The other thing that the reason why it's important to kind of be thinking about the encounter data is that one of the things that Governor Polis has asked the task force to do is kind of look at how do we streamline the state, federal, and billing encounter tracking data that we need to have in place. So how do we make it easier? How do we make it more efficient? How do we make sure that we're aligning those efforts between HCPF and OBH and anyone else that's doing some of this encounter tracking and data? So that is something that we will be continuing to talk about, both within the Safety Net Subcommittee and the task force. So moving on to recommendation number 5, which is really kind of examining funding allocation methodologies for all programs and services. So there are kind of limited funding resources and continued unmet need for services within our behavioral health system that really has directed, at that time back in 2016, which you directed OBH to consider looking at the methods they were currently using to allocate funding, particularly when Office of Behavioral Health receives new funds, and to really kind of think about how can they allocate and use those funds more effectively and efficiently. Thinking that a review of those allocation methodologies could result in kind of new methods that could be simpler, more equitable across the state, and be a better reflection of current needs. And we've talked a little bit within the Safety Net Subcommittee and the task force about the population and needs study that is currently being conducted. This is, well, I should say the Office of Behavioral Health has engaged health management associates to conduct this population and needs study, what we refer to as the PIN study. The end result will be a strategic plan for the Office of Behavioral Health, but as part of their process, they are looking at kind of what are the population priorities, how can resources be allocated better and more efficiently, how can OBH support some of the system changes to improve mental health and substance use services statewide, and when we look at our population across the state, how can we make sure that resources are being equitably invested across the state. So I think it's important for the task force and the subcommittee to know that health management associates and I, as a senior advisor for the task force, are working closely together to make sure that we are continuing to share information, share any kind of initial thoughts around recommendations with each other to stay very much in alignment. What we don't want to have happen is for the task force to produce a blueprint and for HMA to produce a strategic plan for Office of Behavioral Health and have them be going in two different directions. We know that there needs to be alignment. It makes sense for there to be alignment. And so we are working closely to make sure that that happens. I think it's also worth saying, as we're talking about, this WICHE study from 2016, and in talking with HMA today about all of the past reports that they have looked at and they have studied and they have begun to summarize, the needs and challenges in Colorado have been very, very consistent over the years. So again, it goes to kind of why it's helpful for us to look at the WICHE study now, even though it was done in 2016 and things have changed since then. There's also a lot of the same similarities of challenges that we need to overcome and solutions that we need to identify and make sure in our blueprint we lay out how those solutions can be implemented. So we will continue to keep you updated on the population and needs study as those results come forward. So if we look at recommendation number 6, that recommendation is really to look at how do we reduce or simplify the reimbursement methods being used. For those of you who are participating who are providers, I can almost hear your celebration yell across the phone. I know that this is something that's come up several times around kind of the reimbursement methodology, the administrative burden that it currently causes. So OBH, back in 2016, the way that the WICHE study kind of laid this out is that Office of Behavioral Health executes contracts with the MSOs. Sorry, I'm going to back up. OBH executes contracts with the MSOs for the provision of substance use disorder treatment services across different geographic regions that were at that time established by OBH. The MSOs, in turn, then contract with various treatment providers across the state. The multiple OBH reimbursement methodologies that were outlined throughout the WICHE report, apply to substance use treatment providers as well as mental health treatment providers. Medicaid reimbursement methodologies are different, especially for those kind of non-community mental health center substance use providers. So the confusion of the reimbursement methodology and the administrative burden is high amongst providers. I know that we have heard from several providers around we have 64 of these different funding sources in Colorado, and all 64 of those funding sources probably have dozens, if not hundreds, of kind of funding streams behind them, which means that you've got hundreds of lines of coding to have to work through to say, how do we bill this and how do we get reimbursed? So we've definitely heard that loud and clear and know that is something that needs to continue to be addressed. The seventh recommendation coming out of the WICHE study was to implement the suspension of Medicaid benefits for institutionalized individuals rather than have those benefits be terminated. So there has been some movement around this recommendation, which I think is great. HCPF has a kind of incarceration indicator that allows for Medicaid for those individuals to be suspended if they have been incarcerated, and allows them access to kind of some limited inpatient hospital Medicaid benefits. And this is, it's actually federally required and operationalized within their management system, Medicaid Management Information System, which is the kind of really robust system I mentioned earlier. There's not yet the authority or the ability, I guess, or the system functionality to suspend Medicaid eligibility for individuals who are being admitted into one of the state hospitals. But I think that is something that we will probably continue to discuss as needed. Going forward to recommendation number 8, this one was to place more of the administrative responsibilities for non-Medicaid services with the RAES. And I feel like I'm starting to sound a little bit like a broken record here, but in 2016, the provision of behavioral health services by by several state agencies, including the continued segregation of management and administration of Medicaid and non-Medicaid programs by HCPF and OBH respectively, it created challenges then and complexities and inefficiencies as it does today. I know OBH and HCPF are well aware of the difficulties that are created by this administrative structure and have worked together to try to address a lot of the challenges. Over the years, HCPF and OBH have partnered to kind of try to address contracting, allocation, data systems, performance measures, and service definition issues. We know that those also continue to be challenges that need to be acknowledged and recognized and dealt with. Throughout, I think 2014, 15, 16, those agencies have we're meeting monthly to identify opportunities to kind of maximize Medicaid reimbursement under Medicaid expansion, especially at that time, and to develop plans to work more closely together. I think those conversations continue, but I think one of the things we've heard loud and clear, both from the task force and from the Safety Net Subcommittee, is the need for HCPF and OBH to align even more closely and work more closely together, because despite the efforts of the two agencies, there are challenges that remain both for clients and providers. So the system of reimbursing providers for services provided to indigent clients results in sometimes payment errors for clients who are Medicaid eligible, and the absence of alignment of contractors and regions back in 2016. The state relied pretty heavily on provider self-monitoring, and there were limited audits. There's really no way to ensure that contractors were necessarily abiding by their contract terms and not using two sources of funding to support the same service. Again, this is per the WICHE study. In addition to the opportunity for double billing, having multiple administrative oversight entities such as MSOs and crisis contractors, and at that time BHOs, having all those different entities involved in the delivery of the same service is deemed pretty inefficient. Clients who had complaints, especially if they were indigent clients who had complaints, had to contact OBH if they had a challenge. If they were Medicaid eligible, they had to contact HCPF. We had community mental health centers, the MSOs, and other substance use disorder providers who were contracting both with the, at the time, BHOs, behavioral health organizations, and OBH. All of they had separate reporting responsibilities, accountabilities, reimbursement, licensure, regulatory, and quality of care requirements, which is just, again, a heavy administrative burden to carry. And back in 2016, the WICHE study said the current system is outdated. It doesn't serve clients or consumers well, doesn't necessarily lend itself well to transparency, and it's not efficient. The WICHE study suggested that HCPF and the Office of Behavioral Health continue to implement kind of incremental changes, really looking at how to increase auditing capabilities, and to kind of minimize some of the service definitions to make it easier for providers and community mental health centers, and really just try to overall increase the efficiency and effectiveness. So that way, overall, our system could save money and redirect those funds towards providing care. The WICHE fund study did go so far as to say is that, you know, one option that could be considered would be the merger of the Office of Behavioral Health and Healthcare Policy and Financing to create a single state behavioral health authority that contracts with the RAES. This authority would then administer all state, federal grant, and Medicaid funding for behavioral health. And it went on to talk a little bit about licensure and regulatory responsibilities. I know that there's also a task force that's looking at that right now. So again, this is, I feel like, this sounds like a bit of a record on repeat of none of this sounds too different than what we have today and is reflective of a lot of the same conversations that are taking place today. So one of the things that people have said, that I've shared to people, is that because we have been having these conversations for so long, I'd really like the Safety Net Subcommittee and the task force to get to a place where we can say a decision has been made, we're putting a stake in the ground, and we're getting behind it. And then once that decision is made, everyone moves forward so that we're not having the same conversation again in 2024 or 2025. So just to kind of recap, because I feel like I've been doing a lot of talking, just to recap the summary of what we heard within the WICHE study. Back in 2016, more people were receiving behavioral health services than ever before, but many people with serious needs were not receiving services, and the number of uninsured individuals continued to increase. And so that's why we're seeing that a number of people have need for services but lack the resources to obtain those services due to co-payments or high deductibles. There's definitely some disparities that existed back in 2016 in meeting the needs of indigent clients and Medicaid clients. There are lots of variations in costs that are not directly comparable. And then finally, just the indigent funding is critical for serving those clients with the most severe needs. So especially those who are struggling with homelessness, unemployment, and recovery. And again, this is why the work of the Safety Net Subcommittee is so critically important. Having heard, I'll back up just to say, if you've looked at the WICHE funding study from 2016, it's about 70 or 80 pages. It had a lot of information in there, and definitely would encourage everyone to take a look at it. But we wanted to provide this webinar today because it's a lot of dense information to go through, and we know that sometimes people learn better by listening and watching. So we appreciate your time today. The thing that we wanted to share a little bit is that we are undertaking kind of another financial analysis of Colorado's behavioral health system as it currently stands. So we are looking at how state and federal funds are currently being allocated to Colorado's adult behavioral health delivery system. I will tell you that this similar analysis is being done for our children's behavioral health system out of our children's subcommittee. So this effort to look at the funding analysis for children and adults is aligned. And we're looking at the same questions. So how are those state and federal funds being allocated? What services are those dollars purchasing? And then kind of what are those opportunities that exist to reallocate funding to create a more similar or standard experience, high quality experience across all of our counties, to minimize the administrative costs and burden, and to make sure that we are using our dollars most effectively and getting them to the people who need our services the most. So that financial analysis is expected to be done no later than the end of February 2020, and I can assure you that we will be having some lengthy discussions about that in March. And if we get data prior to the end of February, we will continue to share that both with the task force and the subcommittee so that you have access to all of that data. Okay, so I've been talking, it feels like, for almost an hour at this point. I want to pause and see if there's questions or comments that folks have or reactions to the findings or recommendations from the WICHE funding study in 2016. I may not be able to answer all of your questions, but I will certainly come back and assure you that I will find the answers for them if I don't know them. Just a reminder, everybody did join this webinar on mute. So if you have a question or comment that you want to share, please feel free to hit *6 on your phone to unmute yourself, or use your computer screen to unmute yourself if you're using your computer audio.
This is Diane Rivera, Lieutenant Governor. And
hi, Lieutenant Governor.
How are you?
Good, thank you.
I enjoyed your presentation. I had a question about this analysis that we're going to do about how is the money being spent. The last slide that you showed us. Are we also going to analyze not only how is it being spent, but are we getting the bang for our buck out of what is being spent with this analysis?
We are. In fact, I actually think that that is an exact phrase that we used in the scope of work. Are we getting enough bang for our buck? So yes, that is something that we should learn from the study as well.
Great, thanks.
Yeah, thank you. Other questions or comments or reactions? All right, well, I will share. I know that that was a lot of information to digest. If you think of other questions or comments or reactions, please don't hesitate to reach out anytime. I'm pretty sure everyone has my contact information. A couple of other quick things I just want to share specific for the Safety Net Subcommittee is that at our last in-person meeting, we took a quick straw poll to look at what are some of the kind of top 3 things that we absolutely must do going forward to ensure that we have a behavioral health system that works for everybody. And then we also looked at what's the low-hanging fruit, right? So what are some easy wins that we could have for reform within our behavioral health system? So what you can see here on the screen are kind of the top 3 for must do. So central governance, addressing workforce shortages, and aligning funding streams were the top 3 votes for things that we absolutely must do and include in the blueprint to look at our behavioral health reform. And then our top 3 kind of low-hanging fruit or kind of easy wins were telehealth, the alignment of licensing and credentialing, and then there was a tie between central governance and system navigation. So having heard all of that from you, what I wanted to just give the heads up to the Safety Net Subcommittee is that we've started to look at some of the safety net programs and best practices in other states. And so tomorrow I'll be sending out pre-reading for all of you prior to our December 19th meeting that is in alignment with what we heard from you in terms of top 3 must-do or low-hanging fruit. So you'll see here, we've got a couple of examples of things we'll be sending to you as pre-reading, staffing the safety net, looking at workforce shortages, looking at how to address workforce shortages in the rural areas will be in there. looking at other states' safety net systems and the role of counties, which I think is important given how we are structured here in Colorado. The state of Tennessee has undergone some pretty significant changes with their safety net. So we'll be talking and looking a little bit at what they did and what we can learn from them. Looking at just kind of safety net reform and what that has meant across the U.S. and what has happened in some states as a result of that. And then really just understanding, again, looking at some of those states that we've talked to or have learned a lot from already. And of course, Massachusetts is a state that keeps coming up that has some of the best practices. So really looking at what are they doing within their safety net system. So those pre-readings will be sent out tomorrow to the Safety Net prior to our next meeting on December 19th that afternoon. So that's just a heads up. And with that, I'm going to thank everybody for your time today. Thanks for your participation and look forward to seeing you in person in a few weeks.